Thank you for joining, everyone. Please welcome Dr. Cheng.
Great, thanks, Eric. So good morning, good evening, everyone. My name is Alan Cheng. I'm the Chief Medical Officer and the head of the Clinical Research Strategy and Clinical Operations Group here for our cardiac rhythm management business here at Medtronic. So I want to welcome you all. Thank you for taking the time to join us. This is the 19th annual session we've got on approaches to the unknown tracing. And so if we can go to the next slide, Eric, real quick. It's pretty impressive in terms of just the number of folks that have registered for this. There's a simple majority of individuals actually on this that are actually outside of the US and Canada. So special kudos to those folks who are joining, because I know you guys are buttoned against midnight there. So hope your brains are still functional and you're able to sort of actively participate. So maybe we just go quickly to the next slide, and I don't want to spend too much time in terms of the introductions here. It's been a while since I've attended one of these as a fellow, and every time I sort of come to one of these sessions, it was always with a sense of excitement, but also trepidation, because you were worried about getting embarrassed of what you knew or what you didn't know. And George and Mel, you've always had the reputation of being sort of the kinder, gentler sort of faculty folks, sort of walk through the educational process. I haven't seen Rod in action, so it'll be interesting to see how that works. But just a quick note to the fellows that are in attendance. I mean, if you find yourself embarrassed, if it's any consolation, and I'm speaking from personal experience, the degree of embarrassment correlates directly to how much you end up learning and retaining. So my hope is that you'll get a lot out of this, and you'll really see how these luminaries think through problems and get to the solutions. So with that, George, I'll hand it over to you, and thank you all for being part of this.
Alan, that was one of the thanks, Alan. That was one of the best Medtronic introductions that I've ever received. Heartfelt and to the point, and I could relate to it. Rod is a very kind and gentle man. I know that. He's a very bright guy, but he's also a very kind and gentle man and savvy. And I thank him and Mel for participating in this. It's always a great deal of fun. I am just going to say that what I would like to emphasize today, if possible, Rod and Mel are really great teachers, but sometimes they just tell you what the answer is. I just sometimes tell you what the answer is and point that out. But I want to just step back a little bit and ask these guys, when they go over the tracing, how are you thinking about this as a problem when you first encounter it? How do you approach the problem of how you're going to solve it? So that might be the emphasis today. So we'll start with the first one. Mel.
Okay. First, thank you so much for allowing me to participate. It's always a real pleasure working with this team. This is a gem, and this is, and I think it's very wise for George to start with this, because it's a real nice intro into how to approach a complex arrhythmia. This patient was referred over for ablation of atrial fibrillation. The chap who had recurrent episodes of palpitations all the time. So now Moses, when he came down from the mountain, he had 10 commandments. In electrocardiography, we basically have 3 commandments. Okay, first commandment is find the P waves. Okay, so we look very carefully here. We look carefully, and we can see P waves. See, do I have control over it, or should do I have control over the mouse? Can you see me moving the mouse? Do you have to go to view options? Yeah, view options, request remote control. Okay. So, all right. So I have control of the mouse, correct?
Right. I believe you do.
Okay, so I'm looking at this, and I can pick off a P wave here, a P wave here, P wave here, P wave here. And these are regular.
I don't see your mice or mouses. Is it mice or mouses? Doesn't matter. I don't see them.
I think Dr. Scheinman has to click on the slide first before he gains control.
Okay.
Okay.
All right. Now, how about now? Can you see my arrow?
Move the arrow.
You cannot?
I can't see an arrow. Eric, do you see an arrow?
I'm not sure whose arrow it is that I'm seeing.
Well, I can move the arrow. So he requested control
Okay.
and he
All
had
right.
it.
Okay. So the first question is, where are the P waves? Okay, George, so you want to show them P waves?
Okay. Well, you just did this, right? You turn the next slide. And
I didn't do this, but okay. So anyway, can you see my arrow? Can everyone see my arrow now?
well, there are red arrows.
Yeah, I know that.
And-
I wanted to use my arrow. I don't know. Anyway, okay. So the arrows point to the P wave. Arrows point to the P wave. Okay, so we know that. So we're 1/3 done. Now, the next thing we do is we look at the QRS, and we see broad QRSs, and we see narrow QRSs. Okay, so we have to explain the nature of it. So that narrow QRSs are supraventricular in origin. The wide QRSs, we're not sure. They can be ventricular ectopy, they can be aberrancy. Okay, so those are the first two laws. The third law is the relationship. What's the relationship of the P waves to the QRSs? So we have this P wave, and then suddenly we have two QRSs. This P wave, two QRSs. This P wave, one QRS. So that's the relationship. One P wave gives birth to two QRSs. Another P wave gives birth to two QRSs. And then we have one P wave that gives birth to only one. So that's the pattern. That's the pattern. It goes over and over again. Now, there's one other thing about the pattern that is important, and that is if you measure from one P wave to the second QRS, that interval gets progressively longer. Good. That P wave gets longer until you get to this third red arrow. You have a P wave. It's conducting to the first QRS, and there's no second QRS. So basically, the relationship is one P wave conducts to QRSs, and in addition, this one P wave is going down a fast pathway, down a slow pathway, down fast, down slow, until you have Wenckebach block in the slow pathway, which terminates, which gives you the pause, and then the sequence starts again. The reason for the wide QRSs is this is the Ashman phenomena. You have a long short. You have a long cycle because you block from the slow pathway, and then the next P wave that's going down the slow pathway will conduct with aberrancy. Okay, so this is a wonderful slide, and I asked the chap who sent the patient over for the AFib ablation. I said, why you want an AFib ablation? He said, well, that's what the computer read, because these things are totally chaotic. You have irregular RR intervals, you have wide QRSs. So the computer is fooled. It calls it AFib ablation, and actually this was the easiest AFib ablation you'll ever do. Because what you do is a slow pathway ablation. Okay, can we have the next slide? Okay, so this, of all the possibilities, this is clearly a non-reentrant AV nodal reentrant tachycardia. And the basic physiology is shown on the next slide. Next slide, okay. And here, what you have here is a situation where the atrium fires, it goes down fast pathway and fires the ventricle. Then it goes simultaneously down the slow pathway. The slow pathway is slow enough where the distal elements now recover. So you get 2 QRSs for each P wave. Okay, so this is what I want you to remember. One P wave gives birth to 2 QRSs, down fast, down slow. And the unusual thing about the one that I showed is not only did it have a Tupfer response, but it also had a Wenckebach sequence to it. If you look at it very carefully, the distance from the P wave to the second QRS gets progressively longer until you have the drop beat. So that's Wenckebach conduction. And then you have the wide QRS, which always follows the pause on the Wenckebach. So this is just a beautiful, beautiful slide. So I asked my colleagues or audience any questions, any comments related to this beauty.
Okay, Mel, that was a super discussion as usual in your usual way. I'd like to ask Rod, when you look at this problem, how do you think about it? How are you going to solve it? When I first look at something, my immediate thing is panic. All right, then I have to sort of settle down. I either look for it and I want to see it right away, but if I don't see it right away, I need a system. So I'm looking at this thing with a apparently irregular rhythm, some wide ones, some narrow ones. What is your strategy? Mel told us that he looks for P waves, and that's of course very important. But so what is your strategy for solving this problem? You have any thoughts on that, Rod?
Absolutely. So with Wenckebach, we all have to remember and remind ourselves that there's a fixed input, and then there's obviously variable decremental output. So the first key, other than just identifying the P waves, which isn't always easy because sometimes they're masked by the T wave, is also looking at the P wave polarity. And the other observation there, if you look in lead 2, those P waves appear to be upright. So that also is helpful because upright P waves with inferiorly directed direction are unlikely to be retrograde, unless you have something very strange with some rotation. But overall, those are upright, which is a great thing because that kind of excludes some sort of reentrant retrograde atrial activation. The other portion to really focus on is, take advantage of the spaces or the breaks. And George, you always teach everyone about transitions. And obviously what's notable on a gross level is that you have areas in which there are no QRSs. And the question is that tachycardia that terminates with reinitiation, or is that continuation of tachycardia with something missing, with one limb missing? And I think those are the areas of opportunity to be able to attack this slide. The one question I have for you and Mel is, I love the Ashman explanation because it's classical long short, where the His-Purkinje is gauging based on the prior RR cycle length, and the right bundle is not ready to accommodate normal activation. But then you get a repeat of that Ashman on the next beat, but then the next one, it goes away, or there's a very incomplete right bundle. There's a very subtle difference. And one suggestion is really, why does that aberration go away in terms of discussion point? And I don't think we had talked about that at all, but I'm curious to see how you approach that, because the second step of this is all Ashman phenomenon. These are not PVCs.
Yeah, so it all depends on where the impulse that's going down the slow pathway falls within the refractory period of the right bundle. So if it takes long enough, there's recovery of the right bundle, and you may see minor aberrancy, but you don't see the full right bundle branch block. So I think that's what you're playing.
Okay, and I basically agree with that. That's nice to think physiologically. Let me just, I like Rod's approach, and I have my own approaches. As he talked about, the first thing I noticed about this is I'm initially very confused. But the first thing I go to is this hole. I call it a hole or a transition or a pause, which is very, very helpful because all of a sudden now I can clearly recognize atrial activity. And as Rod points out, it's essentially a high to low, most compatible with the sinus beat. And I've got a huge sinus beat. So that's a great starting point. So then I'm going to take my calipers and move it over here on one of these guys. And I see another one of these guys. They're rather obvious. In fact, that's why I picked this beautiful case of Mel's, because, you know, some these can be very difficult, but he's got such a layup for us that it's a great case. So once I identify that first P wave in the hole and I identify the second, I put my calipers up, the rest is gravy. I mean, look at that. The P waves line up, sinus more or less line up, and I can take it backwards here, and they line up. You see here, and even further, one back further. The computer's playing games on me. So there we go. You see back there, and then there's another one back there. So once you see these P waves, you've got a tachycardia. A tachycardia essentially that's irregular, but there are more V's than A's, right? If you look at the list of possibilities with more V's than A's, then it's a very finite possibility. So it's obviously not going to be AVNRT with that atrial activation sequence, or JT, or notoventricular, because Rod has pointed out that the P waves that you see are positive in 1, 2, and 3. So it's high to low and right to left. So you've essentially excluded the first three. So that's all you're left with. If there are no other SVTs, if you will, where there are more V's than A's, all right? And now another way of looking at it is that the differential diagnosis really is atrial rhythm with His extrasystoles, fixed coupled junctional extrasystoles, and fixed coupled PVCs. So you ask yourself, probably fixed coupled PVCs or junctional are probably more common than Toofer tachycardia, all right? But in this particular case, that's kind of unlikely because you have narrow ones that are fixed coupled and wide ones that are fixed coupled. Then you have to postulate you've got PVCs and you've also got His extrasystoles that have the same coupling interval, all right? So if you just go back from a straight diagnostic point of view, you look for this hole in the action because that's going to be your starting point. And then you're going to concentrate on one particular area. Once you have identified atrial activity, the rest of the tracing is essentially a layup because now you've got more P's than QRS's, as I pointed out, with a very finite list of diagnostic possibilities, and it all sort of fits into place. But you notice how that in this particular thing, there are so many varieties of Toofer tachycardia, and some of them really are very tough, especially when you don't see the P waves properly. In this particular one, and I've just got a few backup slides here for this, this is a Toofer, but you actually have retrograde conduction. Often with Toofer tachycardia, you don't have a retrograde conduction, all right? But this one has retrograde conduction. So you've got here going here, and then it's echoing, but it's blocking. So the differential diagnosis of this is again His extrasystoles, but in this particular one, just as well as in Mel's case, then you'd have to postulate you've got PVCs and His extrasystoles, both of the same coupling. This is also not a PVC, and those of you in the audience who are physiologically oriented can ponder why do you know that that's not a PVC? Why is that more aberrancy than a PVC? And the reason for that is in the PR interval. This PR interval is the same as that PR interval. If this were ventricular, it'd be highly probable that PR would prolong because PVCs invariably reach, when there's retrograde conduction, they invariably reach the AV node, resulting in prolongation of the next PR interval. So this is another variant of what we call Toofer, with Toofers with echo beats. Unusual because they often don't have retrograde conduction, the fast pathways, or else you'd see AV node reentry more frequently. Now, this is the same patient with a sustained same tachycardia, in the same patient. So you can see how confusing this guy is. He starts off here, he gets a PAC, and then all of a sudden he goes into an AV-NRT, little short runs of AV-NRT. So you can forgive people for being confused by these and looking at atrial fib. And with Mel's lovely case, the P waves are so big that it's given us a classical prototype. So a way of looking at the problem. How am I going to solve this problem when I see the problem? And the three rules brought down by Mel and Moses are a good thing to think about. And then you have to ask yourself differently: what am I going to do to solve the problem? And in the first case, kind of blends out nicely. Now,
George,
I threw in this.
George, if we could go back to the original tracing, there's a question from one of our attendees,
Okay.
to Mel and us, if we
Sure.
believe that there might be some fast pathway Winky-Bach as well, because the recovery beat after the hole or the gap appears that the PR might be a little bit shorter. Would we agree with that there might also be fast pathway Winky-Bach? Or Mel, was your right there? Is that PR a little bit longer than the
It does, yeah. I think it's a good point.
recovery?
I didn't do the careful measurements, but I think that's
Well, we can try that. I don't want to be there's a fast pathway here. Okay.
Yeah.
And then we pull it over here. And it's pretty darn close, guys. It's a good thought. And whether
the beat
it's
before
long or
block
not doesn't
is a
matter.
little
It's a good
long.
thought.
Yeah, but
Pardon
more to the point than Winky-Bach is that there may be some residual slow pathway influence on the fast, causing delay. In a strict twofer, there's no interplay. In other words, you go down fast, down slow. But there you can have dual AV nodes where you have a dynamic interrelationship where one can affect the other. And I think George had a display of that. One other thing that's important is you can't just do an EP study and say, oh, well, I see a constant HV, therefore it's a twofer, because you have the same problem that George brought out. And how do you know it isn't just junctional premature beats or ventricular premature beats? So the answer would be what you do is you do mild atrial overdrive pacing, and the same sequence occurs, right?
And that topic of the influence of slow on fast is relevant whenever we have a relatively long PR. People are nervous to do a slow pathway. And some people have called that electrotonic inhibition or electrotonic interaction, where actually you eliminate the slow or modify the slow and the PR gets better.
Yes.
So that's relevant for the fellows. And then the only other teaching point I would bring up, the one that George brought up where there was a twofer and then, a little bit of AV-NRT, that's not as common in the classical teaching, that typically you usually have one or the other. And I'm curious to see what Mel thinks there as well, because obviously with classical reentry, you need to have a difference or a gradient of refractory period. And when you have the expression of both of them antegrade, it's less likely to all of a sudden get a reentrant beat.
Yeah, that's very true. And in fact, if you look at the literature, there are relatively few reports of twofers and sustained AV-NRT. I know Mark Josephson reported one, but what you're saying is quite true. The reason you have the twofer is because you don't have this reciprocal relationship where one pathway can affect the other. They're pretty clean. It goes down fast.
Okay, well, that's a great discussion, guys, and we can go on and on about this, especially for those of us who love this sort of stuff. But I will end this by saying I agree absolutely that the reason I showed this is the fact that it's part of the spectrum of the twofers, but it is usually they do not have retrograde fast pathway conduction, or else there'd be more sustained tachycardia. But you can have both. They can be irregular rhythms, and they can have narrow ones and wide ones, usually for Ashman reasons. And that's why they can be very, very confusing. And these days we get ECGs sent to us. I call them crapograms, but somebody takes a phone for an opinion, or a referring doctor takes a cockeyed snapshot of thing and sends it to you for an opinion. And when you have a really tough tachycardia, that does create challenges. So I encourage them to at least take the picture with their phone and try not to try to give you a straight image. Okay, enough philosophizing. Rod, are you okay with giving a kick at the can at this one here? This is
I'll go back. Well, I might not know the answer here, George, but
that's the fun of it, isn't it?
The key here is, just as a fellow or a lifelong learner, is what do we think there? Clearly, there's a pacing maneuver. So that's the first thing identified. And you're giving a pacing maneuver during what appears to be a tachycardia. There again is a hole or an interruption. So there's your transition, which is critical. So that's why just macroscopically, you can see that you've got something fast on the left, a pacing stimulus, and then something slows down. And again, slow down could be termination, or it could be just return to normal sinus rhythm. And then the next question I would say is, where are you giving that stimulus from? And then also, let's make some observations about the tachycardia. So the stimulus is coming from CS910, because you can see that's where the artifact is, the pacing stimulus squared off artifact, the saturation. So you're giving a PAC, and you're giving it during a narrow complex tachycardia. And the relationship of that V and the A appears that it's an A on V tachycardia with a septal VA time of probably less than 70. So obviously, you're thinking AVNRT, JT, or an AT with a very long PR is their first degree AV block or AV delay during the intrinsic rhythm. That would increase the pretest probability of number one.
Okay, that's a good discussion. I look at it slightly different, but this is very important. Those are all great observations. I usually gravitate to something simple that I can understand on the slide and work from there. And often the maneuver that you're seeing, the PAC or the PVC, the transition, sometimes that's the hardest thing to interpret. So you want to set yourself up to be thinking about that clearly. So the first thing I do is look out in left field here, and I see a sinus beat. And that helps me because I see that it's a normal QRS. There's no pre-excitation, no curveballs here. So that's the first thing I will look at. I've identified a sinus beat. Now, the next thing that I find easy to understand is this, all right? The tachycardia, actually, because I have a tachycardia that is a P on QRS tachycardia. Now, I've given you the differential diagnosis, and Rod reiterated that, but a P on QRS tachycardia can only be one of three things. Now, we give you these multiple choice options to facilitate exams and so on, but in true life, you have to make up your own multiple choice question. You have to frame your own problem. So when I look at this tachycardia, I have a P on QRS tachycardia, and I'm framing my problem. This can only be one of those three things, period. So before I even look at what the PAC does, I've got it all lined up that it could only be anything else. Now, if you had to just make a blind guess looking at the overall picture, what would be the answer? Would it be AT, AVNRT, or JT? And you'd have to say, now looking at the sinus beat, if it were JT, would you break the tachycardia with the PVC? And no, how many JTs do you know that where you can break the tachycardia with a PVC and PAC rather? And similarly, ATs are hard to break like that. So just if you had to guess right away, AVNRT is the big candidate. And let's look at the maneuver, the transition you're putting in a PAC. So the first thing you want to see is, well, how does the PAC affect the tachycardia? And so what I do is I take my handy dandy calipers and I put it on the QRSs, and I see that this PAC had no effect on the next QRS. And I'm going to take the liberty of mentally putting a little hiss there, all right? Because we don't have a hiss electrogram here. This is, by the way, Dr. Scheinman's tracing that I picked out of my collection, but I'm not sure if he remembers it. But it doesn't matter because this PAC does not affect this guy. It's a hiss refractory PAC. So it hasn't reached the hiss. It can't be JT. and it can't be AT. Okay, so this has to be getting into the tachycardia over a slow pathway. All right, so this is a little bit of a variant on the Padenillum maneuver, where a His refractory PAC does not affect the next one, but the next one after that. In this particular case, however, though, it actually breaks the tachycardia in the slow pathway. All right. So if we look at the numbers here, we've got 345, 345. It does not affect this one, but it stops the tachycardia, right? And when it stops the tachycardia, the next one comes out as a sinus beat, because the P wave is positive, and it's more or less of the leads we have. It's a central to lateral activation sequence. All right. And this is what would be postulated. So this thing has to get into the slow pathway to stop the tachycardia. Hence, the slow pathway is part of the circuit. Okay. So there's a little variant of this tachycardia from Padenillum, where he puts in a PAC during a tachycardia, which has the same differential diagnosis, by the way. It's a P on QRS tachycardia. And you have I think there's a gremlin out there advancing my slides. But anyway, I just go a little there. Okay, there we see. We have a PAC, and then we go to the Padenillum one. We have a PAC that actually does, if it affects the His, whatever. Let's see. All right, see what this does. This tachycardia comes in, and there's a His, and it's on time. So this would not affect this one, but it affects the next one. All right. And this one is the exact opposite issue, where you put in a premature one, and we look at this. All right. So what this one actually does get the next one. So what you've got now is you got an AHH termination, which is junctional. So this just happens to be a junctional rhythm. The PAC comes in and boots up the next one, and then what starts off is the next slide. All right. So is that anything to add to that, Rod? Perhaps. I mean, this is a Padenillum paper. You should look it up. It deals with how to separate AVNRT from JT, and this particular case is just a variant of that. All right. And that's a slide from this particular paper. If a PAC, yeah, go ahead.
I think the point is if you have a junctional rhythm and the junction fires, it really doesn't care what the atrium is doing. So if you have an atrial impulse fire at the time that the His is committed, in JT, it'll just pop along. And I think that's a very important concept.
That's a good way of looking at it. Yeah.
Yeah. If you have an A that affects the next His, as you showed, then there must be dual pathways, and most likely it's AVNRT. The other thing to remember, which you haven't shown, is if you put in early enough A2, you will terminate AVNRT, because you'll have simultaneous conduction over the slow, and then if an APC engaged the fast and pulled in the next V, then the tachycardia would terminate. That's also part of the Prostowski pattern.
Well, but of course, if you have a PAC, as a rule, junctional tachycardias are almost universally automaticity type of tachycardias. So if you break any SVT with a PAC, that's hugely unlikely to be a JT right out of the box. Okay, so it's another thing to keep in mind. So the simple teaching point, if we just want to go back a little bit and make that point, is that the critical measurement here is this PAC affect the next one or the one after, right? If it affects the next one, it's merely a JT that's been bumped ahead, all right? If it doesn't affect the next cycle, then it makes a change in the following one. It resets or terminates the tachycardia. Then it has to be going over a slow pathway. All right, and I don't know how to make that any more clear, but here we have it. A variant of this, and you might look up Dr. Tan's paper. It's a good paper, but if you don't like to do PACs, you can do essentially the same thing with atrial entrainment. And in this particular case, you are doing the same thing, only you're doing it with train rather than a single PAC. And what you have here is an AHHA. All right, so you've bumped ahead this one. And when you stop pacing, the next H comes in. So this is not an entrainment, but this is more of an overdrive of an AHHV. All right. Well, I think we'll just move on from that, unless there's something else to add to that. All right. So this is the whole spectrum of separating junctional tachycardia from AV node reentrant tachycardia, and just to get back to the quick hitter, the initial patient, you started this tachycardia. This tachycardia actually starts. How does it start, audience? There, you think about this. You got a PAC or a train. It goes over the fast pathway, and then it does this. So it starts with a twofer. Okay, so this particular tachycardia starts with a twofer. Now, this particular patient may not have twofer tachycardia, but he's going to have AV NRT, all right? But the AV NRT starts with a single twofer beat. Okay. Rod, this is a very nice one. Do you want to, Mel, do you want to talk to it, or do you just want to let Rod go through it?
Either way, I'm happy to take it. So
I haven't emphasized the audience polling in particular, because if we polled each case the way we usually do it and give you 5 minutes, we'd be here till doomsday. And hopefully you've all seen the cases before, all right? So if we want to just have a quick poll, give you a minute to throw in an answer, and we'll see what it's like, okay? Let's do that. So let's have the audience poll. We've got 4 alternatives. The options are there. Basically, if you ask yourself what the problem is what are the second beats? Okay. Why is this pattern? Why is there a group beating pattern here? And we'll just give you a minute just to throw something in. Presumably you've seen it before, hopefully. Okay, do we have results? Eric? No? Okay, good. This is a pretty sophisticated audience, I would say, huh? Do you want to talk about the case, Mel?
Okay.
Sometimes,
yeah. Again, going back to can you take that off? Can you take the poll? Yeah. So getting back to the same idea. Rule 1: look for the P waves. Okay. So George has control of it. So we look for the P waves, as we said before. We look at lead 2 and 3. It's positive. Look at V1. V1. The P wave is usually positive negative because you fire the right atrium then the left atrium. So this is classic sinus, as best we can tell. The next thing is we look at the QRS. The QRS is all narrow, so it's all coming from a supraventricular source. Then the third rule is the relationship. What's the relationship? So we look at the first sequence of beats, and we have couplets. We have two, and then a pause, two and a pause, two and a pause. And then toward the end, the last 1, 2, 3, 4 beats, we see something very peculiar. We see long, short, short, pause. And that really makes the diagnosis for us, because the long, short, short represents a Wenckebach sequence. The Wenckebach sequence is not at the AV node, because the PR interval is perfectly stable and normal, but the Wenckebach is occurring in the sinoatrial region. So I think you have a picture of the sinus node firing and then a junction between the sinus node and the atrium, and it is progressive delay of conduction getting out of the sinus node, which accounts for the shortening of the PP interval. This is if you understand AV Wenckebach, then you understand sinus node Wenckebach. And AV Wenckebach, remember, there's progressive prolongation of the PR interval, but the degree of prolongation decreases. So the RR shortens in AV Wenckebach. The same is true of sinus node Wenckebach. The sinus node fires, and it takes longer and longer and longer to get out. So the first sequences that we see here are 3 to 2 sinoatrial Wenckebach. Okay, sinus node fires, takes a while to get out, takes longer. Degree of lengthening gets shorter, so the PP interval shortens. And then the clincher is the 5 to 4 Wenckebach seen on the right. So this is classic sinoatrial Wenckebach.
And the only problem is that you don't see the sinus node deflections, do you? And you were, in the old days, you were a sinus node guru along with others, and you actually recorded sinus node potentials at EP study and validated these electrocardiographic observations. So the diagnostic problem is that you don't see the sinus node potential, and you have to infer what it's doing from the subsequent Wenckebach-like behavior. Now, let's just take a practical, if I might say, horse's ass view of this, and let's say this were an exam question, and I looked at that and I'd see there's a pause here, and then what is the cause of the pause? And these are my choices at the bottom. And now I'm saying, well, gee, I don't obviously know that right away, but I'm just going to go through my possibilities. And this is the other way of dealing with an exam question, for example, and it's what we always do. Is it a blocked premature atrial contraction or extrasystole? Well, I mean, it's the P wave is clearly unchanged from the sinus, right? So it's not going to be a blocked PAC, really. I mean, it's unlikely to be a blocked PAC if the P wave is just about identical, all right? And then the next thing is, are they concealed extrasystoles? Well, why would that be? Because there's a P wave in front of it with a normal PR. It's not obviously not sinus arrhythmia, right? Because it's not a sinus arrhythmia pattern. You know, it's a vagal wave-like slow, more gradual slowing and gradual acceleration. So you've kicked out the first 3 possibilities. So it doesn't matter whether you figure it out or not. It has to be sinoatrial Wenckebach from an examsmanship point of view, if you will. And sometimes that's when you're rushed in an exam. That's an easier way to look at things. And I think that whenever you have coupled beating like this, you always think of some sort of a Wenckebach 3 to 2 phenomenon, whether it's VT or, let's say it was VT. It's the same thing. You look at that, you say, well, maybe it's Wenckebaching out of a VT circuit or something. So we kick this around your case a little bit, Rod, just to try to show the audience a little humility as to how we look at the problem. And as Charlie Fish used to say, it's my slide, so I have the final word on it. So
Nice.
Go ahead.
So I think the major teaching points, again, as George very nicely stated, is we don't see the sinus node impulse or the electrogram on the 12 lead. And that's why it's very hard. Whenever we see a P wave, we say, oh, that's sinus. But we don't see the sinus. This is sinus activation of the atrium. So that's number one. And that's why you have to put that little asterisk and imagine Winky-Bach and slowing out of the sinus to get to the P wave. And that's why Winky-Bach 101 is the PR gets long gradually, but Winky-Bach 201 is the RR gets shorter because the PR gets longer by less each time, which is what Mel so beautifully stated. The last thing about the PAC, which was a question in the chat, is George was saying, well, that's not a PAC because the sinus is the same, but obviously it could be a PAC to block right after the second. But the T wave is really unchanged. So there isn't really any alteration of any T wave, to say there's a blocked PAC. And then someone asked about a concealed His extrasystole. Well, that was a great description because concealed is the whole beautiful terminology we have in EP when we can't prove or disprove something because you can't see it. But the idea is it was used to be able to explain when there's a sudden prolongation in typically the PR interval. And you'll all of a sudden just have a normal beat and all of a sudden the PR gets long. And it's not because there's been a change in atrial input rate. And that was verified by going in, putting catheters and seeing that you get little His extra stimuli that are actually not conducting to the atrium, not propagating anywhere, but probably concealed the AV node. So that's what a His extrasystole is. You can't prove it or disprove it on just the 12 lead alone, but sometimes the His extrasystole will conduct to the V or the A itself or both. But the true concealed His extrasystole you can't see on 12 lead.
So that should probably be your last choice anyway, because it's very rare and only a few of us have our little ones in our collection that we like to show. But typically, this is such a regular recurring pattern. And when you have concealed His extrasystoles, it's a lot more chaotic. So as Rod pointed out, you usually see unexpected PR behavior, right? And it's variable. And then sometimes you see manifest His extrasystoles. So the usual is PR changes that are unpredictable, AV node changes that are unpredictable and a little bit variable. And also the clincher is if you see manifest His extrasystoles. Eric Prostowski shows this beautiful thing repeatedly, but the clincher is the manifest one, so which proves it.
And the
All
last pearl, George, and I know you want to move on, is just the lengthening of the RR, and then obviously gets shorter. The RR is really useful for long cycle Winky-Bach when the PR is super long, because the P is in the T wave. So sometimes you can't always see that the PR is getting longer and longer. And that's when you have to say, oh, my RR is getting shorter before a block. So that's
absolutely. EP and electrocardiography are so visual that sometimes when we think of these things to tell you and to try to inform you, and we don't have a slide, a picture to point to, it's a little bit difficult. So you have to stretch your imagination and try to visualize what people are saying to you. All right. To your point, what you got here? Let's answer the question here. Let's give it a quick audience response. What do we got here? I'm expecting 100% correct here, guys.
Yeah, well, sounds like you had a fun time and saw a lot.
We did. Oh my gosh, we did. We jammed it in.
Maybe somebody can mute themselves there, unless we get into your private conversation that maybe you don't want us to get into. Okay, let's just see what we got here. All right. So just quickly talk to it, Rod.
So again, we have group beating. So Winky-Bach is in the game. It's in the arena. But obviously block PACs, as we just went through, which is why George so nicely paired. Go back one, George. So obviously it's so nicely paired up because it's the same potential differential of a block PAC. It could be something that unexpectedly prolongs the PR. And I think the key here is you can see before the pause in the tracing, the PR does appear to be longer than the other preceding PRs. So you have some level of either Winky-Bach, whether it's progressive, or a switch from a fast to a slow pathway. What's really notable about this is, again, if you entertain all three, could it be a block PAC? Well, we talked about, well, typically you'll see an alteration of the T wave. And it does look like maybe the T wave's changing on the block right prior to it, but it's also with the changing PR interval, which is what's challenging. What's notable is that you have a pseudo R prime in V1, and that's really the pearl here, is that's what we teach you to look for in a short RP tachycardia, because the RP is so short that that's usually indicative of a typical AV nodal echo. And when it repeats itself, it's basically typical AV NRT. So here then you say, well, what's an R prime there? That might be just a single echo. And that's when you have a switch from the fast to the slow. Maybe the fast was Winky-Baching, you can see. It does get longer progressively. And then all of a sudden it switches to the slow and gives you a retrograde activation of the fast that gets into the sinus, delays it, and then there's a slight pause. So in my mind, this is a nice example of just during resting circumstance in ambulatory tracing of seeing a typical AV nodal echo come in, reset sinus, and then create a pause, looking like potentially a block PAC, Winky-Bach, etc.
Yeah, I think
I love this case, Rod, because I actually looked at it first, and I thought, quickly when I first saw it, I thought it was number 2, of course, AV Winky-Bach, and it's a huge pitfall, because if you make up your mind too early about something, and I've done this many times, it's one of my biggest among many problems, is I make up my mind and I turn off my brain, right? Because once you think you've made up the diagnosis, you do that. But this doesn't pass the mustard here, because this is a perfectly nice, regular sinus rhythm, all right? And then if you see my calipers moving along, the next sinus beat should be here. And there's really nothing there, all right? And this is a huge sinus beat. So there's nothing there. So it's not just the Winky-Bach because it's missing the last P wave. And then, as Rod points out, if you look a little more carefully, you see the guy hiding in the QRS, and it's obviously an AV nodal echo. But those of you who said AV Winky-Bach, I fell into the same hole when I first looked at it before I actually started laying out my calipers and measuring it, because this is a nice, huge P wave. I'm expecting it to hear, and there's nothing, all right? So don't make up your mind too quickly before you look at all the data, and always measuring an EP. If I don't have calipers on a tracing or something, I sort of feel like I'm blind. It's almost like my tentacles. And once you use your calipers, then things become sometimes so obvious that you're actually seeing it without the calipers. You have to really imagine it. Any other comments, Rod? Mel, it's a great example of not making up your mind too quickly.
Yeah, I think this is not uncommon that Winky-Bach will terminate with an AV nodal echo. That's exactly what you're seeing. Termination of Winky-Bach with an AV nodal echo. Look for it. You'll see it.
Okay. Now what do we got here?
That was just the magnification of that pseudo R prime.
Yeah. I thought it was such so nicely and obvious from your nice clean tracing, Rod, but that's a wonderful tracing. This I'm gonna let you guys have a go at this, all right? And let's vote on this, all right? I think it's interesting. I've given you, or you've got.
This is an awesome tracing. This is an awesome tracing.
Yeah, I'm not sure whose it. I think it's mine. I think it is. But in fact, it must be mine because I put my mug in the corner. But so I can't disown it. But it's an SVT, and it's vote and see what you got. Hopefully, you've seen it before. Sure, you're all beavering away voting here. Host and panelists cannot vote. Okay. So what we got? Okay, we've got a scattergram. All right, with a predominant for 2. Because why don't you guys want to do this, Rod or Mel?
I can start with some preliminary observations, and I actually don't
Excellent.
know. I actually don't know the answer to this, even though you sent it to us, because there wasn't a clear answer. But what I see is a narrow complex tachycardia, and you clearly have a His bundle electrogram that precedes the QRSs.
This
George,
thing is running away on me.
Yep, someone's moving along.
Yeah.
Perfect.
Someone's moving along, and it ain't me. It's not me.
Perfect.
It's a gremlin. Now, do I have Eric? Do I have control completely? I hope.
I've got my hands up. So what we have here is you could see a clear histoflexion, and then you've got the narrow complex tachycardia. And then what we want to look for is what does atrial activation look like? So that retrograde limb of the tachycardia, assuming it's a reentry, or it could be AT, fine. Well, the earliest atrial activation that I see is in CS1-2. And that means there's eccentric activation, assuming that the coronary sinus is in the normal place, and we're labeling it proximal distal 910 to 1-2. So there's some eccentricity on the activation suggestive of a left lateral pathway. What's notable is that it appears that the third beat no longer has that same activation pattern. It's got a different VA time locally, and the fourth beat no longer has the same exact, and it seems like it comes back to it, but then the fifth beat changes, so there's alteration of the VA. Now, my question, which I don't know the answer to, is, that's the observation. Then the question should be, does that change the tachycardial cycle length?
Well,
Is the tachycardial cycle length constant?
yeah, I as you were talking, I measured it, and in fact, it is constant. So if you look at the RR is constant, even though the atrial activation changes, as you pointed out.
And that's such an important theme of EP, that when some event happens and it affects the tachycardia, then it's critical. It probably participates. And when it doesn't impact anything, it's likely a bystander. It's along for the ride, and it's not a critical limb of the circuit. So if that's the case, then that left atrial activation is not critical, the other component, to the whole tachycardia. So that's the only conclusion I have. Now, the question then is, why would it change? And I can kind of, that's my initial thoughts, and give it to Mel.
Okay, there's something here that's really interesting, and I'd like your opinions. If you look at CS1-2, there's a little blip right after the QRS. Yeah, see that? See that guy? See that guy? Okay, now that guy, you can say, is part of the QRS, or it could be something else. Okay, let's say it's a potential. That potential, the relationship of the preceding QRS to that potential remains constant. So even though the atrial sequence changes, as Rod pointed out, and this changes either from proximal to distal in the CS or vice versa, that potential stays the same. And I think that's the key to the diagnosis of the case.
So what's the diagnosis? Which is your choice, Mel?
Okay, so the choice, this is this is I mean, I knew the answer from before, but this would be an example of intraisthmus block. So you have a left lateral accessory pathway, and you burn in that area. And if you got block at the isthmus, you would have a turnaround. Instead of having CS1-2 first, the septal will become first because of the block. But what doesn't change is the relationship of the V to the initial stub of where the accessory pathway is, which is what I think CS1-2 is showing you here. I think that's a pathway potential. So that stays the same. But what's happening is you have isthmus, block in the isthmus, and it can either go down from CS1-2 as the usual left lateral pathway, or it can block that fashion and go around and mimic a septal accessory pathway.
And that's exactly what we teach fellows to look for when you're doing a mitral line for an atypical flutter. That's, mitral annular flutter, that you pace lateral and you hope to God that you get proximal to distal activation because it tells you that you have mitral block. Well, so that's a beautiful example of that. One of the questions I have for you, George, is you're going to take over the slide. Why, if the tachycardia is constant, does it then go into a mitral block pattern? Why do you get blocked there locally?
Okay. There are a couple of really good questions about this, but let me bring us down to earth for some poor bugger taking an exam or something, and also somebody who's in a lab. So when you're taking an exam, I'm very Spartan on the stem of the problem. All right. So here's this recurrent SVT, previous left lateral ablation. All right. Right. Because all the cases that I've seen of this, and I've seen a couple of case reports, and including one of our own that was sent to us from elsewhere. Of course, elsewhere, because we never screw up. It's always elsewhere, of course. So that you have a stem that says recurrent SVT after ablation of a left lateral pathway. So my little antenna rise from my ears, all right? And what am I looking for with a previous left lateral? All of a sudden now I got a central activation sequence when they previously ablated a left lateral. So I'm thinking of mitral isthmus block. I'm thinking right away just from the stem. That's a huge clue, because people wouldn't give you a clue like that in a question. So if you have a previous left lateral and you've got a second tachycardia, they come back with a second tachycardia with a central activation sequence. Your first thought is mitral isthmus block and not AVNRT or another pathway that kind of creeps up, all right? So that's the stem. Now, the guys quickly pointed out this potential on CS1-2, all right? No doubt about that. But the thing about that is that, it could be an AP potential. I thought it was more of an atrial potential, but it really doesn't matter. It just means it's crossing, the thing is crossing from the ventricle to the atrium at that spot, but it can't go down the CS route, is blocked. So it has to go the long way around, and I've got to back up for that in a second. And it flips back and forth. Now, Rod made an important observation that the cycle length of the tachycardia is exactly the same. It doesn't change. And yet it should change. It should change here if it's all a left lateral. If it's a left lateral, then all of a sudden the atrial path is hitting the node in a circuitous direction. You might expect a shorter, a longer cycle length here, right? Because the route is longer. I'll show you the illustration in one sec. But it doesn't happen. The tachycardia stays the same. It's obviously an accordion effect of the AV interval, all right? So that the VA is a titch longer, but the subsequent AH is a titch shorter, so giving you the same cycle length and fooling Rod perhaps into thinking that it's all one circuit, one unchained circuit, because one part of the circuit compensates for the change in the other, fooling you and because it's giving you the same cycle length. So this is in fact a left lateral that is not dead, but he's achieved intermittent block along the CS, from the lateral CS to the proximal CS. And the atrium locally, or you can call that an AP potential, it could be, is there, but now it's blocking to the CS, taking the long route around the atrium and hitting the CS and going distally again. All right. So this is the same individual. And if you just got this is usually the case. What I've just showed you is a little unusual to have them going back and forth. But in this same individual, you had long runs where you had no isthmus conduction at all. And this is what it frequently will present at. You've done a left lateral, or somebody's done a left lateral. The patient comes back now with a new tachycardia, and people are saying, it's an atypical AV node reentry or another septal pathway we didn't see before. But the first thought should be this. And here the clue is, again, this guy here, because that's too early. It's not part of the QRS. If you draw a line here, it's well past the QRS, as Mel was pointing out. So that's got to be an atrial or a HIS or a AP potential. Okay, so this is the backup, and this is what happens. You've got. It's ironic how sometimes you bust your gut to make mitral isthmus block in an AF patient when you're trying to do it. Something takes hours. Sometimes you even fail. And here, a couple of left lateral burns causes failure of conduction this way, so it goes all the way around. Okay, it comes up the left lateral and goes all the way around. But it's the same pathway, only the circuit is slightly longer now because you've blocked the most direct route back to the AV node. And this is just from the literature. I picked that out from one of the published cases in literature from Dr. Nair, who I know reasonably well, who's a prolific case reporter and has some good stuff. All right. So another way, block here, and it comes up the left and takes a different atrial route. All right.
George,
is there any?
George, can I add two pearls or potential?
Sure, please.
If you go back to the intracardiac, you don't have to take George's word for it that it comes back around counterclockwise. If you look at the HIS-A activation, it precedes the CS proximal. So that's really nice to just complete that whole path, that HIS-A comes next, then you get CSS activation. So that's why there's truly mitral block, number one. Number two, you can call up the referring and tell them where they missed. And the reason why this is atypical, as Sonny Jackman teaches us, you get slants on the inferior portion of the CS, and it's typically V medial to A lateral. And Sonny always teaches us that we ablate too lateral because we're always chasing the earliest A, and you actually need to come here a little bit more medial to get it. This is a case where they missed because they were too lateral. Where they were too medial because they needed to get out further distal. That's why they created block. So you can kind of get a sense of where the prior ablation was based on where the site of block is, the line of block. And you can tell which way they missed.
Great comments. I wouldn't show this case if Sonny were on the panel because he wouldn't let us leave it. He probably, Sonny gets all excited by great cases like this. Okay.
I think
what do we got next?
I think you had a question. Was there a question?
Yeah, I mean, someone asked, is this functional mitral block, George? And it's hard to imagine you get complete block because it's intermittent. Any comments on that?
Well, I mean, your guess is as good as mine. I would just say intuitively that you've given it a hit and the conduction is just intermittent with slight cycle length variability. So I don't think we have to postulate anything terribly fancy. I think it's been injured.
Yeah, I think you could say it's rate related. I think the way to prove that would get them to sinus rhythm and just do some left atrial appendage pacing or wherever, right, and see if it's still there.
Yeah. Good. This is, I like Mel's case, but I think Mel wanted to show the intracardiacs first, but if I would be so bold as to make a few comments on this, because I think that the interpretation of wide QRS tachycardia is so critical to an EP, right? It's probably one of their most important comments, and it's often how you're referring people judge your competence as to how you handle a wide QRS tachycardia. So I think from an ECG point of view, I think it's a good ECG, and I know you have other backups to discuss, but is it okay to discuss just differential diagnosis of this, Mel, for a while? Are you good with that?
Yeah, no, absolutely. That was my intent. That was my intent.
Okay, excellent. So do you want to do it, or do you want let the young guy carry the ball here, Rod?
Yeah, let Rod do it.
Let Rod do it. I like that.
Yeah,
That's
let
like
Rod do
a motto. We put him to work here. I mean, you and I need our beauty
right.
rest.
I'll be sacrificial lamb for the first observations.
Excellent.
So-
But you see, we all have a different approach to wide QRS tachycardia. I have my approach that I like to teach. You and Mel have your own approaches. They sometimes filter out to be more or less similar when you really digest them. So give it a kick at the can, and then the two of us will pipe in.
So whenever you have a wide complex tachycardia and it's left bundle branch morphology, it's a very fun diagnosis. And that's one that you have to memorize the differential, but obviously understand it. And obviously there's SVT with aberration, which is the first choice. The lovely, often talked about but infrequently seen is the atrial which would be something Maheim-like, and we'll talk about atrial versus Maheim's and what the initial descriptions previously were, and then VT. And obviously VT is in the game, but then there's obviously myocardial VT, and then there's conduction system VT, and bundle branch reentry often comes up in that discussion. First thing I look at is if there's overt VA dissociation or AV dissociation, and then also if it's a typical left bundle branch block pattern. Those would be my initial thoughts. To me, this looks like a very classical left bundle pattern. You even have some mid-QRS notching in lead 1. It kind of meets Strauss criteria, which is relevant with the era of conduction system pacing and trying to understand left bundle morphologies with CRT. So this to me looks like a very classical left bundle. And that means pre-excitation. Pre-excitation could be in the game because it inserts into the right bundle, or it could be aberration. I don't think it's likely to be a myocardial VT because it's so typical, but obviously bundle branch reentry is there. I don't see any overt, obvious AV dissociation.
So those are all great comments. I think that the left bundle, I find V1, V2, V3 the most useful for classic left bundle. And if I look at V2, in particular in this case, I see a little R, very sharp, very short, and then a steep ski slope-like descent, virtually vertical almost. That's a classic left bundle, all right? I think that lead 1 can be variable, and they can all be a little variable, but V6. But V1, V2, V3, you need to see that tiny R, and then that very steep descent. That's a very typical one. So I certainly agree. So this certainly leaves out myocardial VT. You know, bundle branch VT, Rod, usually gives you, you know far more about this than I do, but usually gives you a little bit of a screwier looking left bundle. It's not nice. It's a little wider. It's not quite this nice, even if it's bundle branch reentry. So failing further evidence at this point, I would not rule out bundle branch reentry, but I would put it at the bottom of my list and say to myself, I'm looking at something that's coming right out of the right bundle, more or less. So that leaves me with 1 and 2, more or less, and with a distal third being bundle branch VT, because it's such a nice, clean left bundle with a relatively narrow QRS.
Yeah, I agree. BBR usually happens in a myopathic heart, and that's why it's not beautiful. It's not a nice, tight left bundle. It's an abnormal substrate with slow conduction. George, do you think before we give this over to Mel that we could try to be brave and say the P wave may be positive in the inferior leads?
You know,
too hard to tell. I did in the T wave, so it'll be obviously we need supportive intracardiacs, but that might be too bold to try to say what the P wave is.
Probably more mistakes are made by overcalling P waves than undercalling them. Mm-hmm. If I were convinced that this were a P wave, one thing that I think it probably might be a P wave, because if you look at this line here, this is the limit of the QRS, more or less. this P wave is if that's a P wave, it's coming after the limit of the QRS. Okay.
And
So
if
I
that's
think that's
and if that's
Yeah.
it, George, and George is right, and obviously you have to play every scenario, then the P wave may be negative in 1. And Mark and Hein used to love picking that out and saying, boy, if lead 1 is negative, then you got to start thinking left lateral pathways too.
You do. So I think I see a P wave there, but I wouldn't bet my firstborn about that from the morphology point of view. It's not the cleanest tracing in the world, and the cleaner the tracing, the more confident you are. But there it is. If you think you see the P wave, one thing that might be useful is to look for regularity of the tachycardia with both the QRSs. And you ask yourself, if there's a cycle length variation, what leads the change? Is it the P wave or the QRS? Because if it's the P wave, then you've ruled out VT, of course. Okay. So we don't have to go through that motion, but I can just go through. I don't remember what Mel's got up his sleeve there, but it's a pretty regular tachycardia.
Yeah, all those points are fantastic, and you enunciated the Kindwall criteria very nicely, looking especially at the initial part of the QRS, and in our own studies we really validated it. That's very, very helpful, suggesting that you're using the fascicular system. Either it's a SVT with aberrancy, or bundle to bundle, or atriofascicular. The other thing I want you to comment on is, what about the axis? So you have a left bundle and the axis is normal. Does that help you with either of the diagnoses that you have been entertaining?
It doesn't help me in particular, because the ventricular activation with a classic left bundle and with an atriofascicular is probably more or less the same, because it's coming out of the right bundle. And I usually a little bit of leftward axis, but I think it's kind of variable. But you know far more about that than I do, but it wouldn't help me.
Yeah,
Rod?
well, I was going to make the point that certainly the bundle to bundles will usually have a superior axis, but they may not. It all depends on how you activate the left side. With the atriofasciculars, you tend to have more of a superior axis because you're activating the bowels of the right ventricle. You are going into the branches of the right bundle, but it's at the apical region, so they tend to be more superior. But that's a small point. Okay, so so that's where we're at. Could it be SVT? Could it be atriofascicular? Could it be bundle to bundle reentry? Okay, can we have the
How
next?
about just a quick clinical question? If this patient were in the ER, you had to do something, what would you do, Mel?
Okay, for this one, I would not hesitate to use adenosine.
Okay. Rod?
Again, looking at that Kindwall criteria, I would have a very high suspicion that we're dealing with some kind of a SVT with aberrancy. And
Rod?
Well, I mean, PROC is always a safe bet if you want to hedge it. Obviously, if the structurally normal heart, I agree with Mel. If there was something weird about the ejection fraction or something like that, I'd be more nervous about adenosine.
Yeah, we see. I'm not at all nervous about adenosine, and that's my go-to. Was what I tell them that get out of Dodge quickly is just record 12 leads and give adenosine. And the good beauty of adenosine is it's so relatively rapid acting that if by some chance you've made a mistake, I mean, you're not at Walmart, you're in an ER, all right? So you deal with it. But I have no hesitancy for adenosine, especially when there's a strong suspicion that it's going to be like this, like a supraventricular. But even if I weren't entirely sure, but leaning in that direction, then I don't think adenosine is an unreasonable thing, or to give you, if nothing happens to the wide QRS with adenosine, then it's highly likely that the node is not part of the circuit, right? So I think it's very diagnostically useful, but that's an aside. So we've obviously, I think we can come down on 4, need more data. Is that fair enough?
Yeah, sure.
Okay, Mel, go ahead.
You're controlling the slides. Next.
I gave you the next slide, I think.
Okay, so now this is something that happened again and again with this patient. You're sailing along in your wide complex tachycardia with a left bundle, and then there's a premature beat, a narrow beat, and the tachycardia terminates. So we see this over and over again.
That is so beautiful, Mel.
You like
and let's let people vote on that. All right, let's let people vote on that.
Okay.
I just want to see how they vote. I can tell you that this slide, provided you've had an opportunity to look at it, I'm just saying if you haven't had a good enough chance to look at it, it's a different story. But if you've had a good look at it, this will test whether you're an electrophysiologist or not. Okay. Evenly split. Mel, do you want to push on? I think it's fair enough that everybody agreed that it wasn't VT, and VT is a very late coupled PVC, and it normalized the last beat, so that's unlikely to be a VT. So everybody, I think that's fair enough. But have we distinguished between the two?
Two others. Okay, so what I want to do is switch to one of my intracardiacs, if we can do that now.
Mel, could we just, I mean, I think the diagnosis is
go ahead.
There.
Well, go ahead. Why don't you go ahead? Because you have the calipers. Why don't you go ahead and expound on it?
See, the man with the calipers controls the roost, huh? Okay. So what do we have here? If I put the calipers on and you see what I'm doing here, onset's relatively regular, and there's a PVC that comes in. That's a little bit early, but it's a relatively late coupled PVC. Okay, what does that late coupled PVC do to the circuit? What does it do to the circuit? It resets the circuit. Okay, so this is a late coupled PVC that the His has got to be refractory if there is a His. If there is a His. But the late coupled PVC resets the tachycardia and it carries on here. I think it might terminate here, but you'll let us know. But this phenomenon here, all the actions here, a late coupled PVC, and it looks like it's a right ventricular PVC. It looks like it's a right ventricular PVC with lead one being left bundle and left axis, okay? A late coupled PVC resets the tachycardia. What does that prove? Well, that proves that the right ventricle is part of the circuit, all right? In my view, it proves that the right ventricle is part of the circuit. So at this point, so in other words, it's a His refractory PVC. If there were His in front, it would be a His refractory PVC that advances the next cycle, proving the conduction over an alternate way, right? I'm not sure that you've ruled out with that 1 and 2. All you've shown is that the right ventricle is part of the circuit. So that's where I'm left. Rod, do you have any comment on that? It's a very important concept. You've got a His refractory PVC if there's a His, or another way of looking at it, a very late coupled right ventricular PVC that resets and normalizes the tachycardia. So that would help me in what way? To me, it's a classical SVT with left bundle. All right.
I think that's great, but carrying that forward, it always terminates with a narrow QRS. So I think you're like 90% there.
Right. Well, that would make atrial unlikely, because if it were an atrial you can get up the node, because most of the atrial tachycardias are antidromic. Okay. Then it's going up the node, but then the next one would be still pre-excited, wouldn't it?
Exactly.
So that the normalization of that last one, points to number one. All right. So it's all there really on this slide. So you keep that in your collection and ponder, if you don't understand what this discussion and then the subsequent discussion is, think about it, because it's a very key. If you can get into a circuit with a relatively late coupled extrasystole, that means that where that extrasystole is coming from is part of the circuit or has exquisite access to it. Okay?
And
so
also the fact that we have a left bundle branch tachycardia, which always terminates with a narrow QRS.
Perfect. That's another little clue in case you need it. Why would it terminate at that spot when it normalizes? All right. So that's a very, very good addition. Great point. So it's all there, Mel. We don't see the retrograde P wave, but we know how it has to end. Rod, do you have any comments on that?
I've got nothing really to add there. I think that's the only question I have is, could you? So obviously you could argue the PVC is peeling back refractoriness, and then it obviously terminates tachycardia when it gets narrow, which is Mel's saying, which is critical teaching point. But is it only because it's a atrial and it's not capable of retrograde conduction? If it's an atrioventricular, could you still conceal and get rid of pre-excitation and have continuation of tachycardia?
I thought that Mel's point was that the last QRS being normal, that the tachycardia hasn't stopped until after the normal QRS. So if you're dealing with an atrial fascicular, for example, which is your only alternative here for pre-excited tachycardia, then it would have to be going up the normal AV conduction system to reset the circuit, but then I would have to come back down the atrial fascicular again, so that the last beat would be also pre-excited. So the fact that it's normal rules out atrial fascicular reentry. Mel, is that?
Yeah, I think that's good reasoning. And then the second thing is it always ends with a QRS, so it looks like the tachycardia is dependent on the left bundle, right? It needs the left.
It means the left bundle is in the circuit.
Yeah.
Because it cares whether the left bundle is there or not.
Exactly.
Good. So we got all that from an ECG observation, which is so nice. It's the merging of people ask what's the difference between electrocardiography and EP, and there really is none. It's EP just has more leads and more near field leads, and it's in fact much easier than electrocardiography, but they're essentially the same. Okay, go ahead, Mel. Do you want me to move on?
All right. Yeah, please. Next.
This is just a backup showing what's happening here and why you advance the next cycle with a late coupled, probably refractory PVC. Okay, and the little diagrams are the two options that we had, and of course the one on the left is the true one. Okay.
Okay, and then this is just iteration.
This is just a quick point here about the PVC, how it gets into the circuit, but I like to think of if a PVC normalizes something, I like to think of it as pre-exciting the left bundle, right? So that when the next one comes around, it's gained refractoriness. I don't relate to peeling back, I don't understand what peeling back is. I mean, you've got an onion or an orange or what. I mean, but what you've done is you've taken this right ventricular apical beat and you pre-excited the left bundle, giving it a little longer time to recover next time it comes around, and that normalizes. So you can call that peeling back, if you like. But I prefer to think of it as pre-exciting the left bundle. I think it's an easier concept. But anyway, well, I'm pushing on here, talking too much. Okay. Mel, go for it.
Okay, and the next one, basically ties it all together. So here we show initiation of the tachycardia. We're pacing, put in a premature beat. The third pace beat is premature. AH gets a little longer, and then you see initiation of the tachycardia. And it's a classic left lateral, as you can see here. So as George and Rod divine, this patient has SVT with a concealed left lateral accessory pathway, and the patient sails along this way. And then the next slide shows you what happens. So, and it's just what George is saying. You're sailing along in your left lateral accessory pathway, and then you put in a PVC when the His is refractory. The PVC peels back or seals into the left bundle. Now the AH stays about the same. So it isn't a matter of lengthening the time so that the left bundle becomes excitable. It's not that at all.
In fact, it's a little shorter, Mel. If you look at 756 for 2 cycles and 725, you've actually advanced the His.
Yeah.
And in spite of the fact that you've advanced the His, the tachycardia normalized.
Yeah.
Okay, go ahead.
Yeah, excellent point. Whatever. So you can't say that there's delay in the node or delay somewhere that allows for recovery. It's the PVC that peels back refractoriness, allows for the next beat to conduct normally, and now the tachycardia terminates because you need the left bundle to perpetuate this left lateral accessory pathway. So you need a left bundle block going down the right bundle up the accessory pathway to continue. If suddenly the left bundle is not normal, then the tachycardia terminates. This tachycardia needs a left bundle branch block in order to have a reentrant circuit. The next beat is just the junctional beat that occurred.
I think that there's no VA conduction here because this HH is in fact a little shorter. So it needs a longer interval to conduct over this pathway, but this HH is a little shorter, and the normal one gets premature, so that the VA you often see an atrial beat, but it'll be premature and it'll block in the other pathway, right? This one here blocks in the pathway because that HH is now shorter, and you're encroached on the refractory period of retrograde conduction of that pathway. What a great case. Any other comments, Rod, before we leave it? I look at it as an exercise in electrocardiography. And it's a very nice example of how you approach a wide QRS tachycardia, which is essential in our business, right? I mean, the very simple concept is that the more it appears to be a classic left bundle, the more likely it is to be a left bundle. The more it appears to be a classic right bundle, the more likely it is to be a right bundle. And that really embodies all the different criteria du jour that we see all the time.
There's one other variation on the theme where Mel was saying that this always terminates on a narrow. One thing that you'll often see also is because we know the VA is longer with left bundle when there's a ipsilateral pathway, when it narrows, the VA can get shorter, and then your effective AA gets shorter, and then it terminates in the AV node. That's another way things can terminate when you have a loss of aberration. But that's not
absolutely.
That's not this slide, but common in the theme of terminations when it goes from wide to narrow.
Okay, great case. Now, this is one of Rod's cases. And Rod's going to handle most, I mean, he's the entrainment guru and has published some great technologies to visualize slow pathway conduction by imaging and so on. But for this particular thing, he's going to take us back to the classical Stevenson type criteria. But I want to start off, if you might indulge me, Rod. This is just a basic concept, and I want to ask the audience: is this VT overdriven? Is it entrained, or are you not sure? All right, before we look at the intracardiacs. Let's see what it is, and then we'll let Dr. Tung take over and tell us what the answer and why. If you don't understand this, then entrainment, the whole concept becomes muddy. All right. By the way, Ashit, I've forgotten when we finish. We three of us get carried away here, but you bring us back to earth. What time do we finish?
So I think we have about another 20 minutes.
Okay, good. Another 20 minutes. Excellent. It's funny how you get into something, you kind of lose track of time and don't appreciate that everybody else needs to go to the toilet or something.
That means we're having fun.
Yeah, we always do. Probably have more fun than the delegates.
As people are voting, George, there was a comment about your measuring software, and I learned it from George also. It's called Pixel Stick, what George is using there.
And hopefully you would write into Pixel Stick and get them to allow us to make the lines broader. They allow us to change color, but they don't allow it to make it thicker. I've been bugging them, but if you have a mass email it to them, they might be inspired to do the job. Okay, so most people think that it's entrained. So, Rod, you want to talk about that Waldo criteria, so on and so forth? Is this entrained, overdriven, or you can't be sure from what you see?
Yeah, so this is not just a pet peeve. It's actually true definitions, which is why George asked this. Entrainment doesn't mean you pace faster. Just because you dial up something doesn't mean train it. Entrainment implies mechanism, that something is reentrant in mechanism, and you have gotten into the circuit, usurped it, overtaken it, and you're doing continuous resetting of it. And entrainment is predicated upon the presence of fusion. So obviously you have to reset it, you have to take it over and get in faster than it, but you also have to show fusion. And that's what's really critical. And obviously Waldo's criteria is that you have to have constant fusion, progressive fusion, and then often the last beat might not be fused, to be able to show all the different elements that you actually have two different wavefronts that are coming in and creating a child. And the analogy, if you can indulge me, George, is if someone says, does this child look more like the mother or the father? Well, you have to see the mother and the father to answer that question. All children are a product of fusion as well. So you have to be able to see that there's one pure mom, there's one pure dad, and then it looks like it's got features of both. It's not exactly either one. And that's true fusion. And we don't always see that. And in the case here, you've just paced faster. And I would say not sure.
Okay. Now that's going to be an interesting discussion. How many of Waldo's 4 criteria do you need to call it entrainment? Just one. Any one. So what happens here is that you're doing pacing, and I think we should add a 5th criterion to Waldo. We should call him about this and discuss it with him. I think he's still Al's still a very active guy, smart guy. So I would say to you that we're going to add a 5th criterion here, because if you are pacing from the slow conduction zone in the middle of a scar or something, as you well know, and this is what you're doing with this particular case, then you can have fusion with concealed fusion. So the fusion is there, but it's concealed electrocardiographically because you haven't got the electrogram proof of fusion, right? So let's take let's say this were VT that were coming from somewhere, let's say left ventricle somewhere. It doesn't matter where it's coming from site A. Now you've pacing from a different site B, and you've accelerated it nicely like this. You've accelerated it nicely like this. So, and then what happens is, how can you do this? How can you accelerate it by pacing slightly faster without fusion, without manifest fusion, right? The only way you can do that is, it's not going to be a focus, right? It's not going to be a focus because you would have some fusion, wouldn't you? It would not be constant, but you would have some fusion. So this accelerates the tachycardia. You've done no change at all to the QRS, and there has to be a change if it's a focal tachycardia. So I would say to you that this is entrained, and that the fifth Waldo criterion should be that if you are pacing from the slow conduction zone, then the fact that you are able to accelerate the tachycardia without any change means it has to be entrained. All right. I mean, so I think that so that this in itself tells me that it has to be entrained, because if it were focal, I would not expect it to be accelerated with an identical QRS.
But George, here's the problem, George. Suppose this was a focal tachycardia. Suppose it's not an entrant, and you're pacing right over that focus. It'll look like it, and it'll accelerate, but it won't be entrained. That's the issue. In order to prove entrainment, what you need to do, and this is what I badger people all the time, is if most of the VTs come from the left ventricle, quick pace the RV in sinus rhythm and pace the RV during pacing, and that proves entrainment. And then,
go ahead.
No, that was my point.
And I agree with you absolutely. But Mel, what are the odds that you've got a tachycardia like this, and you stick a catheter in, and you're sitting right on top of a focus that you accelerate so nicely with a post-pacing interval that's just about the tachycardia cycle thing, huh? So the post-pacing interval is right. I mean, what are the odds? The odds are about as much as me, landing on Mars from my bicycle. All right. I mean, so for all intents and purposes, if you see this and you just you start to pace and you accelerate it like this, and you have no change, then you're in a circuit, and you've got the PPI is this tachycardia cycle length. So you're in a circuit here, right? So now this is the question is, this is not mainstream EP. I mean, we're stretching the margins of mainstream EP, and I'm trying to add a criterion to Waldo's. So I expected to take some heat from these guys, and I'm appropriately taking heat. But we need to think about this a little further. So I would suggest to you that this is entrained, and it's entrained because it's highly likely that you can pace. You can start pacing like this, get a post-pacing interval that's equal to the tachycardia cycle length, have no change in the QRS morphology that you can see, that would, to me, suggest that it's hugely unlikely that this is merely overdriven. Rod, comment?
I agree with both comments, but I would disagree in the sense that it's so improbable that we can find a great pace map for a focal tachycardia. We often will, for an RVOT, VT, just go pace map and find the best pace map. And obviously, for an RVOT that might be focal, if you entrain it from that best pace map site, it'll probably look something like this. But I agree with all points there. The key is the discussion here. I would think that, George, I'm more compelled if your stem to QRS was longer. I agree there's this little stem to QRS latency, maybe 30, 40 milliseconds. But if you look at it coming off of V2, it kind of, it's not a lot. I think if this was a long stem to QRS, I would agree with you that you're probably doing it from an area of slow conduction, and that's harder to overdrive from an exit site, which is what Mel and I are saying, is you can have a focal tachycardia, overdrive it from the best pace map site, and it still haven't proven that that's a reentrant mechanism. But I think all are correct. It's just the discussion which is critical for the fellows to understand, that you can't just dial up something faster than tachycardia and assume it's entrained. But what George is saying is, it's really unusual to get perfect concealed fusion with a little stim to QRS that really does increase the chances this is entrained.
Well, I think it's
Okay,
only
I like that.
important-
I like that summary, Rod. I mean, I think you're a perfect gentleman, and we should send you to Congress and see if you can get the two sides to agree on something simple, and that would be nice.
Yeah, I think what you're saying, George, is correct, because most of the VTs we deal with are reentry, and so you're right. It's relatively uncommon, but when you do have a focal, one of the things about the focal tachycardias is the closer you are to the focus, the shorter is the stim to QRS. So it can mimic concealed entrainment. That's the issue.
Okay, you guys didn't give me an easy time on this, and I wasn't expecting it. In fact, I'm not disappointed, but it's just so rare to land on a focus, land on a focus and get this perfect relationship. That I still stand by the fact that if I gave another option is absolutely not sure or unlikely, then that might be a better answer. We might say very unlikely. Okay, so no one is allowing me to add a fifth criterion to Waldo yet. So we've only got a few minutes. Rod, I'm going to give you the floor here. And
Dr. Klein?
Yeah.
Dr. Klein, my error. When we meet in person, it's usually 2 hours, but for virtual, you wanted to give a little extra time. So it's your call when you want to end, but we have another up to an hour.
Oh, okay. Well, I'll tell you why. We've got the Rod Tung show coming up, and we don't see too much about classical VT ablation. It's always confused me, and so I think we just let Rod carry the ball and talk to this. Do you want to talk to this, Rod, and carry on?
Sure. I mean, this is what we were talking about, is if you're pacing right next to, you got a focal model there on the left, and George is saying, what are the chances you're going to be right on that yellow dot? Well, the chances are pretty good with high resolution mapping and all the stuff we're doing these days, but what are the chances that the first point you go in the ventricle is the same? That's low. But then obviously when you're pacing from somewhere and you can gain access into the circuit with reentry, you're more likely at any other place, because the circuit's larger, to be able to potentially get concealed fusion. And that's basically the diagram we're showing here. And then you're showing with red and blue different amounts of penetration and different amounts of fusion, which we were talking about, mother and father sort of stuff.
Okay, let me just reiterate what I think I took this from John Miller, because I've seen 50 versions of this, but I like his the best. And the point here is that from a broader point of view, as John, it's worth reemphasizing, if it's a focus, you can either fuse or you can reset, but you can't do both. You can't do both at the same time, because you can get variable degree of fusion, but you can't get into the focus. So a focal tachycardia, you cannot fuse and reset at the same time, and you can't get, you can get stable fusion, but you can't reset at the same time, okay? On the other hand, when you have a macro reentrance circuit, the critical part is that it has a separate entrance and exit, all right? And when it has a separate entrance and exit, you can kick the back door and advance it and come out the exit site, all right? And so that's entrainment. Now, if you think of this in mind, you can think of the rare exception where you can get fusion and reset and it's not reentrant, all right? And one of the examples could be, let's say you have AV, an atrial tachycardia, and you have an accessory pathway, and you can get into the accessory pathway through the, you can get into the atrial tachycardia circuit through the accessory pathway and accelerate it, but it's a focal atrial tachycardia, all right? So this is the key. Focus, you can either reset or fuse, but you can't do both at the same time. Once you reset, you're entirely taking over the circuit there. And with the entrainment model, you've got a separate exit and entrance so that you can accelerate it from the back door and let it come out the front door. This can give you fusion between this guy, that so-called antidromic wave, and an orthodromic wave, as is shown in these things, so that the tachycardia is not going to stop until this three-dimensional model, if you will, until you actually get into the slow conduction zone and totally block the tachycardia. In other words, you're getting into both through the exit and the entrance, and you stop the tachycardia. As long as you still have some orthodromic wave coming out of that slow conduction zone, it could be mainly paced morphology, antidromic morphology, but the tachycardia will continue. All right, go ahead, Rod. Go ahead. Blade here, yes, no, or not sure. Go.
So again, with ventricular tachycardia entrainment, you got this 3-point checklist that just has to be recited. It's almost like the differential for narrow complex tachycardia. It's AVNRT, AT, AVRT. You have to just be able to say it after you've thought about why that's the case. And for VT, you want to know, if you start with the surface always, is there overt or manifest fusion, or is there concealed fusion? So does the QRS look exactly the same during pacing as VT? Point number one. Number two, what is the relationship of the post-pacing interval with the tachycardia cycle length? If you're on the racetrack, it should be the same. And we allow 30 excess, but Mark Josephson even said we probably shouldn't even allow that. If you really are on it, it should probably be within 10 or even 20. And sometimes you can even get a negative PPI, because we often entrain at a much higher output than what's necessary to capture the local potential. So that's kind of the mechanism for short PPIs. And then the last one is looking at the EGM to QRS and comparing that during tachycardia, comparing that to the stim to QRS during the overdrive pacing. And if those are the same, it tells you that the electrogram that you're recording from, that relationship to the exit, is the same relationship as where your stimulus is to the exit. And that gets you out of a bystander situation in which those relationships are not exactly the same. So if we take a look here and say, is this a good site?
Can we let them vote, Rod? You want to let them vote quickly on this one? And it shouldn't be rocket science. It'll give you some idea of how much you have to belabor it.
Perfect.
Go ahead.
What you do, Rod, wouldn't you add to that by being sure that you accelerate the tachycardia to the paced rate?
Oh, yes, that's for sure. You have to make sure you're capturing number one before everything.
Yeah. So I think what you articulated was well said, but
once we have capture established, then you need to get those top three.
Okay, guys, we'll vote here. Okay. Well, that's fair enough, Rod. You do have a significant audience to cater to still, okay? So continue with your tutorial.
The 24% of people need some help. So again, we can start seeing some numbers potentially, but just the eyeball test, the PPI and TCL look pretty good. And then again, trying to emphasize starting with surface, it looks, as we talked about, identical. And when we say identical, I like to use the word cut and paste. It's got to be a cut and paste job. If it's any different when you overlay them, then it's not concealed. That means there's slight overt fusion. And here, at least with these 4 leads that we can see, I think the next slide, George, we have all 12, or maybe not, but that's where you want to look. But if we don't have that as a backup, you want to look at all 12. It's not enough to be concealed in one lead. And it's not enough.
I'm not sure I don't think you gave me that.
That's okay. That's okay. But you want to look at all 12. But in these 4, we like it. It looks pretty similar. I see that it's almost a cut and paste job here. So that looks great. The PPI looks great. And the stim to QRS, I estimated was around 40, but it's 50. And that's why George is probably right that usually you don't see that stim to QRS latency with a focal arrhythmia. But remember, you can get focal arrhythmias with scar around it too. But this tells you that you're closer to an exit site. You're very close to where this figure of 8 shape is breaking out. And you only have 50 milliseconds from where you're recording and stimulating from to get out to the exit. So that's where the Stevenson model of less than 30% of TCL is exit region, 30 to 70 is isthmus, and then greater than 70 is proximal entrance and inner loop. So this meets all three criteria to me. I don't know if it does for Mel and George, but I would say that's a check and reasonable to try to ablate this exit site.
No, absolutely. And you're the guy that taught us a lot about this stuff. And it's much more complicated than this, of course, as we might see in the next couple of slides. But the way I look at it, if you want to look at it simply and you've done a run, then the QRS morphology is an obvious thing to look at. Forget about it if it's not fused with entrainment with concealed fusion. Forget about it. So it has to look the same. But then the next thing to look at is the PPI. And if that's not the same, forget about it. Keep on, looking. You don't have to look at the stem to delta or onset in particular. I mean, just those two criteria are enough to make your decision as to how to get on with it. I think the biggest problem sometimes is that you've got a nice clean tracing here with only one potential Ditzel there that is prior to the QRS in the ventricle, so kind of a late diastolic one. You only got one Ditzel, so there's not too much doubt as to what you're stimulating. So that's why I like this as your first introductory one, because it doesn't get any more straightforward than that, huh?
Exactly. This one is easier. And then the nice thing is, if you look, when we talk about concealed fusion on surface, you can also look at concealed fusion intracardiac and look at any local electrograms that you have. Because if everything's activating the same way around that heart, everything should look the same. And even the RV, that electrogram, the characteristics of it look pretty similar there as well, which is what you would expect.
Right, exactly. And this is, I like to call this the Stevenson hamburger, but because my mind is always on food, but this is this is what you're happening. You're kicking it out down the back door, and it's advancing it on the front door. And the post-pacing interval is exactly one cycle length. The only way you can do that is if you're right in the circuit. All right. So that's a very nice.
And the only modification I would make of that arrow there, George, is I would slide it a little bit closer to the exit, because you're 50 milliseconds from the exit site out of 515. So if you do the Stevenson math and you take 50 divided by 515, you're probably under 10% of the TCL. And
right.
That you're really closer to the exit site.
No, absolutely. That arrow was just meant to show directionality. Exactly. But anyway, this is another interesting one. And now it gets us into the more murky area of what am I pacing from, right? And there's an art to that too. So why don't you guys vote on this quickly and ablate here, yes, no, or not sure.
This is a fun one.
Got to be rare when Rod says fun.
Well,
I mean,
and while people are voting, you have to start thinking about, why would you decide to entrain from this location?
Why not?
But there has to be a candidate, right? You don't just go anywhere and entrain. There has to be a candidate. And if you have a viable candidate, then you interrogate it with a pacing maneuver. And the question here is, what's the candidate?
Okay. Guys, vote even if you're not entirely sure.
And someone in the chat had commented that in a focal tachycardia, if you're doing a PPI, typically if you're closer to the location, it might be a little bit longer. But I think it's variable. If it's a focal arrhythmia, and Mel, you can chime in here, please, you might get different responses. Obviously, if you overdrive the sinus node and the difference from that sinus node, you're going to get different PPIs. But the one thing that you could get is different PPIs depending on rate, but then that's the whole idea of progressive fusion, pace it at different ones. And if you get variable returns, that also goes for focal.
It gets right. It depends on the nature of the focal abnormality. So, for example, Andy Witt's beautiful work. If you have normal, say, automaticity and you overdrive it like the sinus node, you'll have depression, right? If you have an abnormal response, you can have overdrive acceleration. So it gets very complicated in terms of trying to sort that out.
Good, good. I think, Rod, what we need from you is a nice review article on all this. Huh? So if you look at these responses here, I'm terribly impressed that we still have almost 300 people answering on such a beautiful Saturday here. So go ahead and explain to us what your thinking is on this, okay?
Yeah, so 27% said yes, 55% said no, and 18% said not sure. And this one is a slightly elevated level of questioning. So the first question I had is, why would you entrain from this spot? And the answer is, because I see something that's potentially diastolic. And then that is the one that George is circling. And getting away from the pacing spike, that beautiful electrogram of interest to me is the one that's sitting in the middle of the goalposts, right, in diastole. Fine. So then the question is, am I capturing that during pacing? And when you capture, there's three types of capture during pacing. During entrainment, you can get antidromic capture, orthodromic, which is downstream, anti's upstream, and then you have direct local capture. The question is, are you directly capturing that local signal? And the answer is no, because if you were, you wouldn't see it. It would be recruited within the pacing stimulus. But it's sitting there waving at you, unperturbed by that local stimulus. It's probably,
and in fact, what has disappeared?
Correct. What has disappeared is the larger electrogram that was not my candidate. I didn't care about that one. That's not why I came on entrainment. So I failed to interrogate the suspect or the candidate because we captured the larger electrogram one. Now, is that uncommon? Probably not, because scar is harder to capture than normal tissue. So this shows you a limitation of entrainment, that we dial things up to a certain amount and we expect to just capture the one that we're interested in. And just because you're interested in it doesn't mean the pacing stimulus is. So here you get capture of this larger component. So it's not fair to measure your PPI to the one little fraction in one in diastole. You have to measure the PPI all the way out to there. And George will show us what that measurement is. But that PPI is not bad. It's not bad. It's probably, if you go the other direction, George.
No, I'm trying. There's a gremlin, Rod, but there it is. But that's just that explaining the hamburger diagram.
Correct.
And there. How's that?
So we got 365 as our PPI and 325. And yes, I made the mistake again. I went into the intracardiacs without talking about surface, and I made a mistake, and I'm sorry. I want everyone to start with surface first, because that's whether it's concealed or overt manifest fusion. And if you look at the last captured beat, actually looks like a cut and paste job with then the next beat down the line. And the nice thing is the stim is inside the QRS. So you know that the last captured beat is the one that's not obscured by the pacing stimulus. So that one is its full pace beat, and then the next one looks exactly the same. So I would say there's actually concealed fusion. That's step one. Two is the PPI TCL, and there's a 40 millisecond excess there that you don't want to see. I wish you could trim off that 40 milliseconds, but you can't, because that's what it is. So we don't allow 40, and probably 30. It's not that far, but it's definitely not right in it. And then if you look at your stim to QRS, the stim to QRS is longer than the electrogram to QRS during tachycardia. And this, when you add up all three levels of evidence, is consistent with bystander. An adjacent bystander, AKA, in the bystander one in the picture there, AKA dead end, AKA blind loop. And the reason that is because when you pace out of that blind loop, you got to add that extra distance it takes to get to the racetrack to the exit site. And that's critical. And that's why it's a little bit longer. And that's why that extra distance is also responsible for your post-pacing interval. You got to get to the racetrack, do one revolution, and then come back in to the recording site in the blind loop. And that's why your PPI is longer. That's why your stim to QRS is longer as well. That difference, by the way, the PPI minus TCL excess, is exactly the same, or should be about the same, as your stim to QRS minus your EGM to QRS excess as well, mathematically. So this is basically the entrainment of an adjacent bystander. But you're recording something that was a candidate, but you were unable to really assess the relevance of the potential of interest. Now, there is no backup slide here, but I have it, and we can always send it out. But we came on ablation here. And why the hell would you do that? Well, because we recognize we didn't actually entrain the potential of interest, and it's so juicy and diastole, you got to take a crack at it, and it terminated in 2 seconds. And the whole point is, if you don't recognize this limitation of recognizing what's captured and what's not, yes, I got a bystander response, but I'm trying to ablate the electrogram in diastole, and it worked. So it's a really nice lesson about how you have to be understanding of all the potential pitfalls and what's captured.
Excellent, Rod. I'm a little confused. Why did it work? Because you seem to be near an exit site.
Because I'm also recording the isthmus potential too. So we have to think that just because you have a big bipole or whatever the size of it is, we probably record more, and adjacent bystander might be only a couple millimeters away. So you could have simultaneous recording of two areas that were pretty close to each other.
All right. So I get from that it's better to be lucky than good. I mean, or is that not? It's not. Or the other lesson you might get is, if you get entrainment with concealed fusion, you might as well just bang away at it, because you know that the downside from a quick burn is not huge, whereas it might get you out of there quicker.
It is, but if this is on your boards, you would say this is a adjacent bystander and do not ablate.
Exactly. Well, that's a really good comment. So this would not be, I won't think, a high percentage ablation shot, huh? I mean,
but it's because you also have the isthmus recording in the middle. If you don't have that other component, then it's very clear it's just a mono recording of a bystander. The point is that you're also recording another component of the circuit here because you have two electrograms.
I see. So you know that because you see your juicy one, along with it, it has to be close.
Correct.
So maybe this is a tongue criterion now added to the Stevenson stuff, that if you see your juicy component in mid diastole, in addition to the one you're pacing, you might as well go for it.
And then in the era of activation mapping, there's many of us and other people that don't even do entrainment. They see something really diastolic and you burn it.
Yeah. Okay.
Now, Rod, would you comment on the first of the potentials that you're seeing after the paced beat in the ablator electrogram? Now,
this one, that one.
Yeah. Do you think that's artifact? Do you think that's orthodromic?
Oh, that's real.
What's that?
That is real because it's consistent during the tachycardia, and that's the one that's the one of interest.
Yeah, I shouldn't have said artifact. What I meant to say was sort of a
non-combatant.
Yeah,
non-relevant.
Yeah, not involved in the circuit. Just a stray electrogram. Because
my point is that's the most critical component of what's being recorded on ablation distal. It's not the one immediately under the QRS that we captured. That's the reason this terminated, because we're recording that component. But
the very fact that you're recording it on the same electrode suggests that it has to be close.
Yeah,
and if you look at your hamburger model, bystander 1 doesn't look too far from the common pathway.
But your stimulus to that potential is very short.
The stim to that potential is too short because that's orthodromically captured. It's not directly captured, so you don't remeasure to the orthodromic downstream components. You measure to whatever is locally captured.
But you don't know where that thing is. That thing could be anywhere. It's not drawn to the stimulus. I mean, if it were part of the circuit, it would be drawn to the stimulus and it would be bang on.
Correct. So it's captured downstream, as Mel is what you're saying, It's not
Orthodromic,
captured, it's orthodromically captured downstream, but
right.
it's not directly captured. And therefore, you don't measure your post-pacing interval to that electrogram because it would be so short. And you can see the stim to that electrogram is constant for the 3 beats of pacing, which means it is orthodromically downstream captured.
So, Mel, this is a great discussion, but I'm going to invoke the Charlie Fish rule that it's tongue slide, so he has the last call on it. We're getting, I think it's probably worthwhile doing this one, maybe 1 or 2 more, and then we'll let everybody off. Rod?
And George,
let's
the flyer said 2.5 hours, so if we stop around 10, then I think we're great.
Yeah, it said
15
2.5 hours just to give us
Yep.
a little more leeway, but we don't want everybody to die out there of exhaustion. So you just take your time. Let's take a little vote here. I think your tutorial is probably very valuable to us, so you go ahead. Ooh, come on.
There was a question in the poll that said, how do you get those clean electrograms after pacing? That's just dumb luck. You know, sometimes you get saturation, sometimes you don't. But there's no question, the higher output you do, the more saturation effect you're going to get. And then it's putting things on booms, et cetera, and trying to minimize noise as well. But the lowest you can actually capture is ideal. I'd be remiss to not honor John Miller. How do you try to capture that diastolic? Well, you got to do some sensing and maybe make it sense the QRS and then come in at a different time. So when you entrain matters. So sometimes we'll just push the button and then it entrains. But obviously, if you want to train the diastolic component and you want to try to get that electrogram, then you want to try to entrain during the diastolic period and not during systole. It increases your chances of capturing that local potential of interest. The other one is entrain at lower output. But the point is that lower output, you probably won't capture the lower electrogram one.
Yeah. So ideally, the higher voltage you use, the more likely you are to get far field captures, and that's not good. And the wider your spacing is, the more likely you are to see far field stuff, and that's also not good. So let's move on, Rod. So obviously we got something to talk about on this particular slide. So why don't you talk to the slide? This is
Scheinman's rule number 0. Before my top 3 was 1, 2, and 3. Scheinman invoked a new rule, which is you got to make sure it captures. So the question is, do we capture? Well, where is the stimulus? The stimulus is sitting just a little inside the onset of the QRS. So if that's the case, you have to be accelerating the tachycardia to the next QRS because you can't affect the one that you're in. And then if you take a look at the local electrograms that Gremlin keeps getting us,
we're ignoring it.
If you look at the electrograms, what's the local potential of interest? Go back.
I'm trying to go back, Rod.
Perfect. Right there. Right there. We're great. So the local there has a really beautiful, sharp potential that's pre-systolic. And then you get this larger component that happens at a QRS onset. But it doesn't appear that we capture that directly. You're not getting local capture. Now, you could get it downstream, as we talked about, orthodromically, which is possible. Then what are you capturing locally? Well, then you're probably capturing the second component, which is more far field, but you can see it's already ramping up before the stimulus. So it's unlikely you're capturing that either because it's already taken off before you've done that. So this is a classical example of no capture, that you're not pacing fast enough. And when George pushes the next slide, it's 480 and 480.
Yeah.
And the only reason the QRSs look a little bit different is because you've got the stimulus artifact inside the QRS. Other than that, it's perfectly concealed. Now, why is it concealed? It's pseudo-concealed because you just didn't capture. So every time the 12 lead looks like a cut and paste job, the first thing is maybe you're not that great, and you didn't get that lucky. You just didn't capture because the VT is going to look exactly like itself when you don't capture it.
And I think that the relationship of your second, realistically, you probably in this slide should have shown us 5 or 6 pace cycles. They would become a little more obvious.
Mm-hmm.
But even if you look at your first 2 paced ones, the stimulus, its relationship to the QRS is a little bit different. a slightly different. I don't want to muck with the calipers because I'll again lose it. But it's a slightly different. The second stimulus comes a little later than the first one relative to the QRS. Anyway, so the rule here is make sure you're pacing at a cycle length that allows you to see a difference. So in other words, it's usually going to be more than 5 milliseconds. So maybe 20, 30 milliseconds. You don't want to pace too fast because then you'll get conduction delays obfuscating your measurements, right? Which are based on geography. Your measurements are based on geography. But if you muck with the conduction time, you are losing the value of your geography measurements. So a great example. Do you want to at least do one more, Rod? Here?
Yeah,
I mean, I think
this one,
there's a good one here.
I think this is
a nice
one. Great one to end on. That, why don't we get a poll? Let's not even say anything.
Yeah.
And George, you asked for a review, and I did write a brief review in CircAE, so I just posted that for the participants.
Perfect. Thank you.
In 2017.
For the participants and me, by the way, I'm always trying to learn something.
It's in the chat.
Okay, guys. Another scattergram.
Love it.
Good. It's almost a perfect scattergram.
Yeah,
So you need to discuss.
Majority like this as an isthmus. And then some people like it as an outer loop, and some people like it. Oh, this is great. Okay. So that's an opportunity. Well, let's start with number one. Well, let's start with Scheinman. So let's start with step 0. Does it capture? And here it does look like there's no alteration between the relationship of the QRS and the 3 stims. If you take a look at even V1, there's something that looks peaky, but that's probably an artifact from the stimulus itself. But it clearly doesn't look like it's walking away or towards the QRS, the stims. So I think that fulfills Scheinman criteria for capture. Number 2, is it concealed on surface or is there manifest fusion? Well, remember, if the stim is in the QRS, then the last captured QRS is the one hanging out, unobscured by the pacing artifact. So this is your last captured beat, the one that George has right there. That's it. And that last captured beat is very easy to compare with the next beat, which is VT. I see a cut and paste job. So to me, that's concealed on these 4 leads, concealed fusion. Then the next question is, which component are we capturing? Because we need to measure a PPI. So the fellow gets their caliper, let me measure it, and they're like, oh, wait a second. Which one do I measure to? And that's the whole point. Which one do you measure to? Do you measure to that first one there with this little QR complex, or do you measure to the fuzzy little electrogram? Now, we like to say that fractionated and sharp high frequency equals near field, and non-high frequency, low frequency equals far field. So let's just say, let's use those arbitrary terms because we don't know how near is and how far is. But let's use the term that the first component is the far field signal. Do we like that one? Okay, let's play that forward, that scenario, and say that's the one that's captured. Well, if that's the one that's captured, is it gone when we're pacing? Is it directly recruited within the pacing spike? And the answer is, I don't really see it in the pacing spike. That went backward. There you go. Perfect. I don't see it in the stimulus. Fine. So that potentially could be captured. Okay, well, what about the next one? The local potential that we actually are interested in. It's the one that's in diastole. Remember, there's no reason to entrain a signal in SCAR-VT that's systolic. It's in the QRS because that is past the exit in the outer loop. We're looking for the central common pathway, which is in diastole. You got to go in between the goalposts. So that's when we're interested in. And when you look there and you say, is that captured? The answer is, it is. Because if it weren't directly captured, it would be sitting there during the stimulus, and it would be somewhere there. But then George is pointing beautifully, unrehearsed, that there's a little bit of saturation, and I can't be 100% sure it's not gone because of the saturation, but I can rely on my neighbor ablation proximal. And if I go down there, it's not there. And that means it's been directly captured by the pacing spike. So that's the only thing I can be sure of, is I need to measure to that electrogram. And as a matter of fact, George, if you see it, you can see that proximal electrogram component right there, right after the pacing spike. Right there. It's got that same characteristic, a little sharp notch and then kind of a downstroke down with a terminal inversion. It's there, which means you're definitely capturing the earliest component of the ablation distal. So I hope everyone can appreciate the subtleties of those electrograms. And then we have to measure to that near field potential. There's a possibility you can get simultaneous capture of both, but for the simplicity at least, which George likes, let's just go to the near field potential. And then we know that that's a long post-pacing interval. So if we measure ablation there to that near field potential, it's quite long. And if we have a follow-up measurement slide there, George, there it is. It's 635 to the sharp local diastolic potential of interest. And the tachycardial cycle length is 485. So the difference is 150. And again, if the stim to QRS is longer than the EGM to QRS, which it also is, it's 315 versus 165, that difference is also 150. This is consistent with the bystander 1 on the hamburger model of where you're in training from, because it takes time to get out of your blind loop, out of your dead end, out of your bystander to get to the racetrack. So you have to add that difference to the whole cycle length. And that's why it's long. But it's concealed because the only way out of that blind loop during VT is out the exit. And that's why you don't see surface fusion.
What a great case. What a great case. I'd like to actually end on that note, Rod. I think we've had a great run, and the three of us disagreed with each other often enough to make it a little more interesting and showed individual approaches. And I've learned biggest problem I have in VT ablation like this, when you're using the classical technique, is deciding where I'm pacing from, and which ditzel am I capturing. And that was a great tutorial on that. So I can end it all there and thank all the participants and Sheeta and the Medtronic folks and Eric for great technical backup. With some apologies for my slide jittering, but I think it all worked out well, and that's it. Any last minute comments or housekeeping, Ashita?
Yeah, that was an awesome case to end on, and thank you so much. Eric's just going to bring up a few quick slides, and most importantly, our team, Babette, Cindy, Rich, Sarah, Eric, and I wanted to thank all of you, our attendees, for joining. We have almost over 200 of you from across the globe. So thank you very much for being here on a busy Saturday, different time zones, but for being here with us. Next slide. And none of this could have happened, Dr. Klein, without you kind of pulling it all together. So thank you for leading this. And Dr. Scheinman and Dr. Tung, thank you. The discussion between all of you has been amazing. With that, we want to go to the next slide and just ask if you could put your phone up by the QR code. Anymore, it's not, you don't even need to give instructions. I think everybody knows what these QR codes do. But just put your phone up there if you could, or click on the links in the chat box. We will look for your feedback and share it with the faculty and make improvements for future courses. While you're doing that, I just wanted to put in a quick word for next slide, our online education. So if you go to Medtronic Academy or fellowspace.com, there is so much more of where this came from. Under Find Education, you can click on the different options. It takes you through various learning points.
their courses, their pre-recorded programs. Our entire team information is there. If you have questions, just click on the links. We'll get your questions and direct you to the right contact. And with that, we close the program. Next slide. Just a quick thank you to everyone everywhere. And we will leave the page open with the last slide of the QR code. So the QR code is there as you're dropping off. Just take a moment and give us your feedback. Thank you very much to all the attendees and most importantly, our faculty. Thank you.
Thank you. Great job. Enjoyed
Thanks,
it.
guys.
Learned
Bye-bye.
it.
Have a good weekend.
See you guys. Bye-bye.
Bye. Everybody's bucking. Just us. Well, I'll see you're on mute, but it's have a good Saturday, Babette.
So, are we still? Can everybody?
No,
Yep.
I think
Yes, we are still
Eric,
live.
Thank you.
Oh,
Thanks, Eric. Thanks
you
for
can end the
helping
recording.
us
End
out,
the
and
recording,
Sarah.
actually. Yeah, I'll stop it.
Recording stopped.
Thanks. Thank you, Eric. Thank you, Sarah, for hard work. Thank you.
You're welcome.
Yeah, thanks, guys.
Turned out pretty well. Rough start. That was funny. It was actually like
Let's wait till everyone gets off here.
Yes, we're still live.
We're still live.
Well, Doreen's still on. Hey, Doreen, you got to say something. Doreen's still on.
We need to see Doreen.
I know.
I told her she needs to volunteer for ECG Club.
I'm trying to do the remove. It's not working for me.
Same here. So I can't do it.
Play some bad music or something, maybe. I am multitasking here. Got the computer going. Well, anyhow, I guess I should jump. We have some fans. Maybe their computers are still connected, you know.
I'm working on it here.
Okay.
Oh my.